Alterations in elimination, gastrointestinal, disorders of the lower gastrointestinal tract. The lower GI tract includes the small and large intestines. We may see constipation. The pathophysiology of constipation is we have stool that is very dry, compact, difficult, and painful to pass. Basically, it's defined as having fewer than 3 stools per week for several weeks. We may see peristalsis decrease. We may see abdominal distension. We may also see gastrocolic reflux. And of course, we see stool retention. This can be from insufficient dietary fiber. It might be from inadequate water, impaired GI mobility, and systemic disorders. Now, I want you to understand that constipation can be different in a variety of people. Some people only have a bowel movement once a week, and for them, this is very normal. The key is what does the stool look like? If it's dry, compact, difficult, and painful to pass, that is constipation. If they have a bowel movement once a week and it is soft, formed, moist, easy to pass, non-painful to pass, that is not constipation. So always look at the stool. So these clients with chronic constipation may be from a neurological issue, partial or complete blockage of the intestines, muscular disorders, or hormonal conditions. These clients are going to have infrequent bowel movements, distended bowel or abdomen, abdominal pain, and they may have liquid stool, which can be kind of confusing because they have an impaction and stool now starts to seep around that impacted stool. So it almost seems like they have diarrhea, but it's not really diarrhea. We need to do an examination, and this may include doing a rectal examination. We can do x-rays, barium enemas, or an anorectal motility study. These clients may require laxatives, enemas, stool softeners, improving the fiber in their diet with legumes, fresh fruit, vegetables, wheat bran, seeds, and nuts, increase their fluid intake and their physical activity. So some of the laxatives and softeners are basically going to facilitate bowel movements. We may do this also to prepare for a diagnostic procedure or surgery with the colon. There are a variety of different laxatives available. One of the most important things is that we increase the fluid intake. So let's talk about some of these different drugs. We have those bulk forming laxatives. They're going to actually increase water absorption by increasing the total volume of the intestinal contents. This might be your methylcellulose or your psyllium. These clients have to have increased fluid intake to prevent blockage because of this bulk forming laxative. We have emollient laxatives that will lubricate or soften stools, and that will be like your docusate salts or your mineral oil. We have hyperosmotic laxatives that increase the water content of the feces. It can result in distension of the abdomen, peristalsis, and evacuation. And this can include glycerin, lactulose, or polyethylene glycol. Your saline laxatives are going to increase osmotic pressure and draw water into the colon, producing a watery stool. This would be an example of magnesium salts. And then we have stimulant laxatives that induce intestinal peristalsis, such as bisacodyl or senna. So again, consider what the stool is like. Is it hard? Is it difficult or painful to pass the stool? Again, some clients may only have one stool a week, but if it's soft and formed consistency and easy to pass, that is not constipation. True or false? The stomach is part of the lower gastrointestinal system. This is false. True or false? Constipation assessment findings include infrequent bowel movement and distended abdomen. This is true. So diarrhea. This is a frequent stool, defined as more than 3 a day, liquid, semi-liquid, with increased peristalsis. There may be dehydration and electrolyte imbalances and vitamin deficiencies. Causes of diarrhea can be infections, the diet, an intestinal disease, medications, or formula that's used in tube feedings. It can also be caused by an infection. And I said that. So these clients have frequent liquid or very soft stools, hyperactive bowel sounds, and potentially skin impairment. So let's think about this for a second. With diarrhea, things are moving through the gastrointestinal system very quickly. And what is in our stomach? Hydrochloric acid. So if contents are moving through the system very quickly, that hydrochloric acid is also moving through the system very quickly. Well, our stomach is designed to be able to handle that, but our rectal tissues are not. So if we have diarrhea, that stool gets on the surrounding skin and it can become very sore and very excoriated, very irritated. It hurts, it burns. So these clients may require a barrier cream to keep the stool off of those tissues. We diagnose diarrhea by looking at stool cultures. We're checking for ova and parasite analysis. We're checking to see if there's any blood. We can do a proctosigmoidoscopy, a colonoscopy, or an endoscopy. Treatment will be dependent on the duration of the diarrhea. We may give medications, we may give probiotics. We need to make sure that fluid and electrolytes are replaced if they are imbalanced. Dietary adjustments may need to be made, and TPN, total parenteral nutrition. So what dietary adjustments? Well, a BRAT diet, B-R-A-T, is often recommended in the cases of diarrhea. This would be bananas, rice, applesauce, and toast. That's going to help bulk up the stool. So just the same with constipation, we need to pay attention to diarrhea. What does that stool look like? There are some people that have more than 3 stools a day, but the stool is soft and formed. As long as it is not liquid or semi-liquid, it is not necessarily considered diarrhea. So there's several medications that we can give to treat diarrhea. These are called antidiarrheals. They can cause constipation. So as usual, when we're treating for one thing, we have to make sure that we're not throwing the client into the opposite condition. We also need to make sure these clients are getting plenty of fluids. Some of the different antidiarrheals that are out there would be adsorbents, which would be bismuth subsalicylate, anticholinergics, which would be belladonna alkaloid combinations, and belladonna can have some narcotic effects. Opiates, which would be our dithenoxylate with atropine or loperamide. In other words, there are some narcotics in antidiarrheals. So we have to be very cautious when we're administering those. And probiotics, which would be our lactobacillus. True or false? A patient with diarrhea has hypoactive bowel sounds on auscultation of the abdomen. This is false. They're going to have hyperactive bowel sounds. Irritable bowel syndrome is also known as a spastic bowel. Functional motility disorder is what it is, and we see a cluster of symptoms with no known disease process. These clients have a fluctuating intestinal motility that intensifies with stress. This is an issue that occurs more often in women and younger adults. These clients can have either chronic constipation or chronic diarrhea, but there's no blood and their weight stays stable. They may have abdominal pain, bloating, and flatus with this process. We can do x-rays and do endoscopic tests to help identify any potential disease processes going on. So we definitely need to encourage a high fiber diet in these clients. They will be on some medications, which may be anticholinergic or antidiarrheals. There are IBS specific drugs. Understand that IBS can have diarrhea or constipation. So it's really important to be familiar with what type of issue this client is having and make sure that they are getting the appropriate medication. Make sure that these clients are eliminating alcohol and smoking and that they have appropriate stress management. Another irritable bowel disease would be Crohn's disease. This is defined as a regional enteritis. We have a chronic digestive disorder that has systemic manifestations, such as arthritis, skin lesions, eye inflammation, and liver or gallbladder disorders. Crohn's can occur anywhere in the GI tract, but primarily in the terminal portion of the ileum. So we see inflammation in the submucosal layer. Affected areas are going to be edematous. So we have hyperemia, we have ulcerations, and we may have fistula development. Causes of Crohn's can include a genetic predisposition, smokers, and Caucasians with a European or Jewish history. These clients will exhibit bilateral lower quadrant distension, tenderness, chronic diarrhea, fever, and growth failure. Basically, nutrients are passing through too quickly for them to be absorbed, so they're not growing appropriately. We need to do a stool analysis, monitor the white blood cell count, the ESR, so the erythrocyte sedimentation rate. We may do barium enemas and endoscopic examination, biopsy, an upper GI series with a small bowel follow-through. We treat it with supportive cares, monitoring that diet, giving TPN to make sure they're getting appropriate nutrition. We're going to maybe transfuse whole blood, give antidiarrheals or antiperistaltics, corticosteroids, and immune modulators. Surgical management is reserved for complications such as obstructions, perforations, or fistulas because with Crohn's disease, we can remove that diseased area, but it can recur. So we have to be aware that these clients may have what we call the short bowel syndrome. They may require an intestinal transplant. They may require an ileostomy. 75% of clients with Crohn's will require surgery within 20 years of symptom onset. 90% will require surgery within 30 years. So it's really important for nurses to monitor for complications and make sure these clients are getting appropriate fluid and nutrition replacement. Ulcerative colitis is a chronic inflammation of the colon and the rectum. It is an immune-related disorder, but also has genetic predisposition. Can also be caused by infection and allergies. This issue is most common in young and middle-aged adults. We may also see a toxic megacolon develop where the colon dilates and becomes atonic. So it basically loses its peristaltic abilities, and that can lead to emergent problems. These clients have an abrupt onset, diarrhea, blood, pain, pus, and mucus, dehydration, anorexia, sudden bowel urges, where they're having 10 to 20 stools a day, and they can have exacerbations and remissions. We diagnose with a barium enema, endoscopic exams, proctosigmoidoscopies, biopsies. The goal of treatment is going to be to achieve remission. We treat with the diet, TPN with lipids. Surgical procedures are appropriate. Blood transfusions, drug and fluid therapy. We monitor the stools and monitor for complications. We need to teach the client about medications, their diet. They need to increase calories and nutritional content. Appendicitis. This is the inflammation of a narrow blind protrusion at the tip of the cecum. Appendicitis is most common in adolescents and young adults. Inflammation is occurring when this opening becomes narrowed or obstructed. Then we develop a bacterial infection. These clients have pain that begins around the umbilicus, then it moves to the right lower quadrant, or what we call the McBurney's point. These clients also exhibit rebound tenderness, where you're palpating the stomach and you release it suddenly, and that causes intense pain when you release. They may have a positive Rovsing sign, where pain is felt in the right lower quadrant when we're actually palpating the left lower quadrant. Other classic symptoms of appendicitis include low-grade fever and elevated white blood cell count. Nausea, vomiting may also be present, including constipation, and rupture might occur within 24 hours of the pain onset if it's not treated, and this could lead to peritonitis or an abscess. We definitely need to do a CBC and get that white blood cell count, potentially an abdominal ultrasound and or CT scan. These clients may require antibiotics. They definitely need IV fluids, and appendectomy is essential. We initially withhold analgesics in clients suspected of appendicitis, so the pain is not masked uh, if there is a potential rupture. So these clients come in and the nurses have to do a quick preparation for surgery. Then, of course, we provide appropriate postoperative care. These clients have to avoid heavy lifting or straining for months after surgery, although general activities can usually resume sooner. Remember, if the nurse begins to palpate the stomach and pain is felt, the nurse stops palpation. You can cause a rupture. Peritonitis is inflammation of the peritoneum or the lining of the abdominal cavity. It can be caused by a perforated peptic ulcer, perforated bowel, perforated appendix, the irritable bowel disease, a ruptured ectopic pregnancy, infection from peritoneal dialysis. These clients are going to have a lack of bowel motility followed by hyperactivity, and then they may develop a paralytic ileus where the peristaltic activity stops. They may have rapid respirations. They may progress to hypovolemic shock. This is a life-threatening issue. These clients, we need to do a CBC, look at that white blood cell count, x-rays, CT scan, ultrasounds. We may do a culture and sensitivity of peritoneal fluid. They will require an NG tube, IV fluids, electrolytes, antibiotics, antiemetics, and surgical closure of the perforation. It's very important to monitor these clients' status, provide emotional support, and postoperative care. An intestinal obstruction is a blockage that interferes with the normal progression of intestinal contents. It can be functional or mechanical. It is more common to occur in the small intestine. If it is not treated appropriately, it can be fatal. Again, mechanical, adynamic, complete blockage, or partial blockage. These can all be caused by a tumor, adhesions, which are scar tissue that attaches to an abnormal area, causing a blockage. It can be caused by hernias, a volvulus, which is a kinking of the bowel, intussusception, which would be the telescoping of the bowel, or fecal impaction. These clients will have distension, emesis, and if we have blockage, you know, where are those fecal contents going to go? We're going to vomit them up. So we can have emesis with bile or fecal contents, abdominal cramping or absent bowel sounds. Perforation symptoms, remember, anytime anything perforates or ruptures, we have a sudden severe pain. In this case, we'll also have abdominal distension and a fever. We diagnose with x-rays, serum electrolyte tests. We may see metabolic alkalosis, white blood cell count elevation, hematocrit levels may change also. We treat it with IV fluids, electrolytes, antibiotics, intestinal decompression, and that's what the NG tube is going to do. It's either going to decompress the gut or it's going to allow gut rest. We can also do a colonoscopy. They may require surgery, and some blockages, depending on location and severity, may require an ostomy. It's very important for us to observe the vomitus, monitor these clients' status, and report urine output below 50 mLs per hour, because in these clients, that may indicate shock. Diverticulosis and diverticulitis. Diverticulosis is basically those little herniations or pouches in the GI tract mucosa. It may be asymptomatic, but if we have diverticulitis, we have inflammation of those diverticula. Usually this is caused by a low fiber intake. There may be a congenital predisposition or inflammation when it becomes obstructed and abscesses form or fistulas form. Other factors for the development of diverticulosis would be obesity, a lack of exercise, smoking, and some medications. These clients may have alternating constipation and diarrhea. They may have rectal bleeding, causing those stools to be maroon color or appear like currant jelly. So it has that consistency to it. When we, excuse me, when we have a GI bleed, we need to really observe what we're seeing. If we see coffee ground emesis, for example, this could indicate that we have a bleed in the small intestine or somewhere in the stomach, or that blood has sat there for a long period of time. The closer to the orifice in which the blood comes out, the brighter the red it will be. The longer it takes for the blood to pass through, whether it's going up or down, the darker it will be. And that can be a clue as to where that bleed might be. We diagnose diverticulosis with stool specimens, CT scan, barium enema, and colonoscopy. These clients have to avoid food that contains small seeds. They need to be on a high fiber diet. They may require antibiotics. They may require a colectomy where part of the colon is removed, or even a colostomy. Very important to educate clients on the appropriate diet to avoid constipation and laxatives and encourage fluids. And then we have colon and rectal cancer. This can develop anywhere in the lower GI tract. Colorectal cancer is the third most common cancer in the United States. We may see a benign adenoma. We may see an adenocarcinoma. Polyps are considered to be a precursor to colon cancer. It may be caused by genetics. So we may see ulcerative colitis or a poor lifestyle environment. They may have chronic bowel inflammation or a long-term low fiber, high-fat diet that has led to the colon cancer. These clients are going to start seeing changes in their bowel habits. They may have blood, they may have diarrhea, they may have constipation. The stool might be very thin and pencil-like uh, because of compression from the tumor. Again, we may have occult blood, distended abdomen, and abdominal discomfort. We're going to do a CBC, maybe a barium enema, a colonoscopy, genetic screening, a CE test, and or biopsy. So we need to routinely examine polyps if they are discovered through x-rays and colonoscopies. With colorectal cancer, surgery, radiation therapy, chemotherapy, colectomy, segmental resection, or abdominoperineal resection. And then, we definitely are going to do appropriate postoperative care.